right. Thank you, Abbas, for the invitation, and thank you, Yang, for the introduction. It's a great honor to give a talk here at the BrainMap Seminar Series. So today I'm going to talk about two technologies, namely the near-infrared optical tomography and MR elastography that can offer different image contrasts for cancer management and imaging. And those are technology I think you guys are not encountered on a daily basis. So today, is it the fun thing? Okay, got it. So my talk is split into two parts. One is to use the near-infrared diffuse optical tomography for breast cancer imaging. So I know a lot of you do brain research, so allow me to take a detour to breast imaging first. And then the second part, we'll talk about using MR elastography that measures the stiffness of the brain for brain tumor imaging. So first off, I'll give you a brief introduction on near-infrared optical imaging. So some of you might not be familiar with this technology, but if you work in the field of functional MRI, you may have heard functional near. So basically, it uses the same principle. So it's basically leverage the near-infrared light in this, we call the optical window, where the absorption of water is relatively low, which offers us opportunity to measure the concentration of deoxyhemoglobin and collagen fat once in the tissue. And these are endogenous imaging contrasts. We don't need to inject any contrast, and optical imaging is relatively safe. It can penetrate pretty deep inside the tissue compared to other imaging technique. But we call it diffuse optics because near-infrared light enters the tissue and bounces back by multiple scatterers in the tissue, so it doesn't take a straight path forward. So the image is not as high resolution as the MRIs you typically see, but it contains functional information such as the oxy-deoxy. So the sum of the two offers information of how much total blood in the tissue, and also the oxy divided by the total hemoglobin give you a sense of the tissue oxygenation, which can be interesting, especially for cancer imaging. And cancer has several hallmarks. It's a complex disease. So it has to orchestrate a series of genetic mutations and altering the cell signaling pathways so it can acquire the sustained proliferation and survive and overcome the native healthy tissue. So sustainable chronic proliferation is arguably the most fundamental trait of cancer cells. And its tissue level manifestation can be measured by diffuse optical tomography. For example, cancer is known to have angiogenesis and abnormal blood vessels growth, so that can offer an interesting contrast in the so-called total hemoglobin concentration. And so tumor is known to have increased level of HBT. And also aggressively grown tumor tends to be hypoxic. So by measuring the tissue oxygenation, we can have a sense of how aggressive and whether the lesion you see is malignant or not. And then in that process, the growth of the tumor also need the support in the microenvironment. For example, cancer cells is densely packed with atypical cells, and also there's excessive deposit of collagen fibers in the extracellular matrix, which can change the collagen and water content, and also change the scattering properties of the tissue. So these are the functional biomarkers we leverage using near-infrared optical imaging. So in the field, we use near-infrared for cancer imaging because it offers hemoglobin-based biomarkers very sensitive to cancer pathophysiology. And in our group, we started using diffuse optical tomography for breast cancer imaging well over a decade ago because the optical imaging requires surface measurement, meaning the optical sensor need to be close to tissue, and breast tissue is just the one tissue that is very accessible by this technology. And our group started with using diffuse optical tomography to differentiate the malignant and benign lesions in the breast. As for example, in this figure, you can see that malignant tumor has a much higher hemoglobin concentration compared to the benign case. And this is a work we done a while ago. And in the last several years, Stefan and I have been looking into whether we can use diffuse optical tomography to monitor the treatment of breast tumors to the response of breast tumors to treatment. So as you all know, breast cancer is the most common cancer among women worldwide. And every year, because the accessibility of the screening technology, more and more women are diagnosed of breast cancer at early stage. This gives a better opportunity to fully overcome this disease and have better survival rates. And one new strategy that the clinical management of breast cancer use nowadays is called neoadjuvant therapy. So when the cancer is diagnosed, before they move to surgery, they will give several rounds of chemotherapy just to see how tumor responds. And the purpose of this is so research have seen that the neoadjuvant therapy can improve the overall survival of breast cancer patients. And also for women with larger lesions, neoadjuvant therapy can help reduce the size of tumor to make it operable and to have better outcome. And also this window gives the opportunity for drug trials. So there more and more targeted therapies and some like to enter the market, and people have been using this neoadjuvant chemotherapy to see whether tumor is responding to this kind of drug, and if not, after surgery for the adjuvant chemotherapy, they'll use a different drug to try to improve the survival. But the problem is currently the response of the treatment is only assessed at the time of surgery. And so based on the pathology assessment. So pathologic complete response, or PCR, is only clinically validated surrogate of the outcomes that can be linked to longer and overall survival of breast cancer patients. However, the PCR rate, depending on what type of breast tumor cancer you have, is very heterogeneous, so ranging anywhere from 5 to 50%. So, and the surgery evaluation happens after the chemotherapy, which is 4 to 6 months later after you start this treatment. So you can imagine for women who do not respond to the treatment, they only find out 4 months later and they went through all those unnecessary side effects and to get the treatment that is not working for them. So our goal is to identify functional imaging markers using optical imaging that can provide early prediction of PCR, and that allows doctors to change the treatment in the middle of the neoadjuvant therapy if necessary to improve the overall outcome. And we'll explore both static and compression-induced hemodynamic contrast in the study. So I'll explain what it means later. So we have engineered this tomographic optical breast imaging system we call TOBI2, and it is a hybrid system. So it combines optical imaging parts with the clinical digital breast tomosynthesis, which is the X-ray mammography. So the optical part instrument looks like this, has a lot of fibers. Because we have 122 source fibers that connect from this card here through these cables and to like all these, you see this the arrays on the compression pedal. And then we have 48 and 24 RF and 32 and 20 RF detectors on the other side of the breast. So the breast will be positioned here and the compression pedal goes down here. And then this is the X-ray detector, and we have an optical detector covered over it. So we can do, well, the original plan is to simultaneously do optical and X-ray image, so they can be natively spatially co-registered. But we later find out that the X-ray actually over time, it degrades the plastic fiber. So we have to replace one's glass fibers that cast shadows on the X-ray. So we have to do a separate compression for the optical and X-ray image. So for that, we place some web cameras to capture the shape of the breast. The purpose we do that is because for optical image reconstruction, we need a volume to reconstruct the optical property once in the tissue. And this spread shape help us to create this tetrahedral mesh clouds that once which we can resolve the optical property on each of the nodes of the mesh. So you can see this little dots here. So basically those are source fibers. On the other hand of the breast, there's the detector fibers. So basically we're using the source measurements of different source detector combination to resolve the internal structure of the breast. So the imaging protocol takes 3 stages and with varying levels of compression. So the first stage, we start with a half compression, and then we proceed to the full mammograph compression for 60 seconds, and then partial release back to the half of the compression. So you can see the tissue, the bulk hemoglobin concentration within the tissue changes with response to the compression. So in this study, we'll look at the hemoglobin concentration within each individual compression period, but also will explore the dynamic changes like how tumor respond to the compression across different compressional periods. And after the optical imaging is done, we'll acquire a separate DBT compression, DBT measurement, so give us the structural guidance of the breast geometry. So we conduct this clinical study, a pilot study with a cancer center led by Dr. Steven Isikoff. So we recruit patients for a baseline scan before they start the neoadjuvant chemotherapy. And then we invite them back for a longitudinally pre-cycle 3 scan before they initiate the 3rd cycle of infusion. And we offer an optional pre-cycle 2 scans as well, just to see whether we can predict the PCR at the even earlier time point. So our target population are women with triple-negative breast cancer and with HER2-enriched or HER2 plus breast cancer. And we're not interested in people, women with ER, PR positive, because these patients respond pretty well to hormonal therapy and have overall better outcome. Question, yeah.
Question for me. So basically, when you are compressing the tissue and letting it come back, is that basically now your optical imaging is just, are you just looking, what are you looking at the physical properties of how the tissue is responding to that mechanical force, or the combination of that and other things?
So the question is, once the compression, are we looking at the mechanical property changes of the breast or something else? So like once optical imaging, the fundamental image contrast comes with hemoglobin and based contrast, but solid tumors take the compression differently than the surrounding tissue, and this mechanical response difference result in different of hemoglobin, like the blood distribution difference between the lesion and the background. So even ultimately we're measuring hemoglobin, but that is driven by the mechanical response of the breast tissue to the compression. So we totally recruited 22 patients, and several dropped out before we start, and they're missing data in a few other patients. So eventually there are 14 patients we included in this group analysis, and 5 of them achieved PCR and 9 did not achieve PCR. And additionally, there are 10 patients participated in the optional pre-cycle 2 scan, and among them 4 achieved PCR and 6 achieved non-PCR. So we have collaborating breast radiologists to mark the lesions for us, and we use the lesion marking to guide the optical image reconstruction to have better contrast recovery with DOT. And we use this, we keep the baseline image marking in the later scans just to capture how the tissue changes once in the lesion area for the data analysis. So the two quantitative metrics we're interested, one is obviously the total hemoglobin concentration, which is the hallmark of the tumor, we call HBT, and the other one is normalized oxygen saturation. So our primary goal is to see at the mid-treatment cycle, like pre-cycle 3, can we see difference in normalized HBT in women when achieve PCR or non-PCR. And we also want to explore other imaging biomarkers such as tissue oxygenation and see if we can differentiate the PCR, non-PCR cases at the earlier time point. So before we get into the group analysis result, so just the sample case. So this is a woman who achieved PCR eventually. You can see that at baseline, the normalized hemoglobin ratio, which is the value within the breast lesion divided by the one outside, is over 2, and over time it decreased and not significantly higher than the surrounding tissue, although the size did shrink over time. And in this case, second case, the lesion started not very big, but had very high HBT contrast. Over time, there's moderate decrease, but still at the pre-cycle 3, there's pretty high contrast in the tumor still, although the size has shrunk dramatically. So using that metric and at pre-cycle 3 at the mid-treatment point, we did see between the PCR and non-PCR a significant difference in normalized HBT. And when compared to size-based metrics we derive from DBT and IMR, these are not significant. I think IMR is very close. I think it's because this variation is too big, and the sample size is very small because not all patients receive consented to do an actual MR. And then we will look at other imaging markers and at early time points. So normalized HBT at pre-cycle 2 is not significant, which means the decrease in HBT comes later. And similarly, the size at pre-cycle 2 is also not significant between the two groups. However, if we look at the tissue saturation in response to partial release of the compression, it's significant at both pre-cycle 2 and pre-cycle 3, indicating it could be an earlier predictor of treatment response. So we did the receiver operating characteristic analysis using leave one out cross-validation. At pre-cycle 3, you can see HBT has a higher area under the curve compared to size-based metrics, which is consistent with our other groups' research. And at pre-cycle 2, HPT performance is not that great. However, the SO2 picks up and has a pretty decent performance. And so we use a quite conservative data analysis. We use the data leave one out cross validation to put our AUC values in comparison with literature reported values that translate to like close to 90.9 0.85 HBT area under the curve for HBT, and at pre-cycle 2 that area under the curve is even higher for tissue oxygenation. So in conclusion, near-infrared optical tomography is a low-cost, non-invasive imaging modality that offers functional hemoglobin-based imaging markers that can be used to differentiate the treatment responses, and is more effective compared to size-based evaluation, and especially total hemoglobin concentration at mid-cycle is predictive of final pathology outcome of PCR. And additionally, tissue oxygenation change on blood volume refill during reducing compression from full to half is also a promising biomarker for predicting PCR at even earlier time points. So I'm gonna pause a little bit here. That's 5 years research in 20 minutes. So if you have questions, like feel free to ask. And if not, I'm gonna. Oh, someone is called. So Randy asked a question, does compressing the breast wound's tumor during functional optical imaging have any negative impact due to increased metastatic disease, mechanically induced tumor spread? We don't think so, because compression is compression is typical like for X-ray mammography, and our compression does have much longer time than the clinical one. Clinical one can be done in a few seconds, ours like 60 seconds. But I don't think there's no research to show prolonged compression can cause increased metastatic risk. So that we didn't investigate into that. Thank you for the question.
Yeah, I have like when these compressions, is there any, well, like thinking mechanically and like tissue geometry, I mean, is there, or is it just like isometric, I guess, isotropic in all directions, or is it like it can be done, like I'm thinking about people in the mechanical lab when they do these stress and strain tests, like they do it on different axes and directions depending on the material that.
Yeah, it's definitely not isotropic. So breast tissue has glands and ducts. They're like connective tissue fibers and fats. So they do have like different response to the compression. So we actually have a paper studying the relationship between the compression and the hemodynamic changes, and we use the Fabio to simulate the compression in breast. So you have to make some assumptions. Yeah.
But in terms of the device, that's just like one type of, I guess, compression or vibration. Or
so the parallel plates.
Yes.
So that's the typical configuration for breast exam. So we just simply add optical measurement on top of that. So the purpose is that because X-ray mammography is the first line screening tool for breast cancer, and by integrating optical imaging device with that, we expect to have the widest reach to the potential patient. There are other groups integrate optical imaging with ultrasound and MR. Yeah, all three different kinds of major breast imaging technique. But that's just our choice.
Thank you.
All right, so how do so we have built this imaging system to combine X-ray mammography with optical with X-ray mammography, hoping to bring this technology to the clinics. However, the technology is pretty much still in the research space. And one of the reason we think is because the image reconstruction process is very, very time consuming and it's very limited in different ways. I'll talk to you later. But from the raw measurement here to the image here, I probably skipped like 2 hours or maybe a few days. It doesn't advance. One moment. Can you tell me how to close this window? Like it's blocking this advanced bar. There was a question, but the question is answered and the window stays here. Yeah. Oh, great. Great, thanks. So as you can see, the data is very noisy and reach the noise floor here. And also we need to create a mesh based on the DBT contours, and Elish can tell me how painful to do the lesion scanning technique to make sure the lesion prior is in perfect alignment once the optical space. So all these processes very labor intensive and time consuming. It's not fit in the fast paced clinical workflow. So nowadays, clinical are pushing same day biopsy. So people get diagnosis in the morning and biopsy in the afternoon. So there's no such luxury of like taking all these process to get the image. And also the optic image reconstruction need expert parameter tuning, need deep knowledge in the diffuse optical tomography. So it's a technical obstacle for the physicians to use. And also the traditional finite element-based image reconstruction uses regularization because it's very sensitive noise. So the regularization helped to get your stable solution, but also had the side effect of function as a smoothing filter that cause the image to blur. So our goal is to leverage the recent advances in deep neural network and see how it can help us achieve real-time, high-quality DOT images to accelerate the clinical translation of DOT for breast cancer imaging. And with that, we work with the QTM lab with Dr. Jashri and Chris to use machine learning for DOT image reconstruction. And being at Martinos, there's no way to bypass the AutoMap work published by Rosen lab. So we started from there. So we started with sending the raw optical measurement to a fully connected layer to translate that into the image space, and then use a convolutional autoencoder to get to resolve the abnormality once in the background. So we
Why is
Can you say it again?
why is it that middle step white going into
Like here, this one. So basically from this step to this step is just the ray shape. So we can use the convolutional layer to work on directly on the image space.
Oh.
Yeah. And we tried that. You can see that with the tiny plot, it's not very great. So what Hanxue in my lab did was she put a UNet after that. So that helped a lot in increasing the denoise the image. And so we give this network a very simple task. Can you resolve a single spherical inclusion within a homogeneous background? There's no way that is close to the real breast geometry, but we start from there to understand how the model works and help us to benchmark. So we randomize the inclusion size and location, and also the optical contrast to cover a wide range that is physiologically meaningful. And the training is nothing fancy. The only thing I want to point out is that we didn't use a traditional L1 or L2 loss. Instead, we use a prior weighted loss function because so how it works is we know where the inclusion is, the location, the size, and when we calculate loss, we put a weight on the inclusion. So we want to ensure the small inclusion is as accurate as possible compared to the vast majority of the background. So this helps us not only get the global accuracy, but also highlight these small areas, although small, but they're important. So we trial and error the volume fraction factor here and the weight factor here. So the weight factor turns out to be close to the volume fraction of the inclusion to the back compared to the background. And this prior weighted loss function is only needed during training. So once it's trained, we don't need this information for image reconstruction, meaning we don't need prior for optical reconstruction to use this network. So for to evaluate the performance, we simulate another 400 cases with a discrete size group, so we can see how the reconstructed image is dependent on size, because we know optical imaging is challenging towards small lesions. So as you can see here, we use two metrics. So root mean square errors and structural similarity index measure for 4 different reconstruction methods, namely the FDUNet, and then the FDNet is only just the fully connected, and the autoencoder without the UNet, which is compared with another deep learning method. And the finite element-based methods are the traditional ways we use for optical reconstruction. And we use the one with prior guidance to supposed to get better reconstruction outcome. And the one without prior is just use the optical image by itself without any structural guidance. So as you can see here, the deep learning based method by together has a marked improvement compared to the conventional finite element-based method. And if you compare the two deep learning-based methods, the FDU net has further improvement in quantification accuracy in the overall image. But so this one?
Yeah, basically, like for the rest of them, it seems like
Mhm.
it does out, but not significantly. But as diameter increases, it seems like your stats out more.
I think it has something to do with our the image. I didn't mention that. So we did downsample to save the calculation speed. So we did downsample the full field of view into like a 3:5 downsample ratio, and we use the filter size on 3 by 3. So when that coarse downsample for small size, you will have a very difficult time to like. I think the point is once that coarse sampling and the larger filter size, you're challenging in smaller lesion, even using the FDU net. So the thing we really care is how well it can reconstruct the inclusion contrast. So when we look at the scatter plot for 4 size different groups, and each data point is one case, and I compare the 4 methods again. So the FDU net works pretty well as larger inclusion, especially for 14 millimeters, almost like lining along the y equals x line. And the next best performer is actually the finite element based, but once the prior guidance. So this one, we gave the structural information. We tell the reconstruction there is a lesion at this spot and what's the size. So in this way, the traditional method can recover decent amount of contrast, but realize that the FDU net actually got better performance even without the structural prior information. But when you look at the smaller size group area, is still like recurring maybe half the best. So it's still challenging in small groups. And we're also interested in how accurately can recover the inclusion shape, and also how close the recovered contrast to the ground truth location, because for diagnosis, localization is important. So we calculate the off-center in the XY plane, and at 16 there's seems like not much trouble, but however at 8 smaller lesion size, it's not accurate regardless what method you're using. And so if we put all the small lesion metrics together and you look at this, you can see it's still not ideal for small sizes. And the small lesions is quite important because like 30% of the clinical, like the lesion seen in the diagnostic setting has lesion less than 1 centimeter. So we have to address this in order for optical imaging to be adopted for clinical translation. And also for therapy monitoring, if the tumor is responding to the treatment, the size will shrink. So the size accuracy towards smaller size is important. And once this much contrast recovery, we're very close to like is very limited sensitivity to small lesions. And also once the size inaccuracy, you will have false positive. So that's not great. And but we can see here, like as I mentioned earlier, once the prior guidance, it can really help even with the conventional method. So our next goal is to see whether we can leverage the high resolution structural information for this purpose in our FDU net. So I'll use a sample case here. This is a 8 millimeter diameter, smallest size we tested, and this has a relatively high inclusion to background contrast ratio. And you can see once only fully connected and the autoencoder, we kind of get the ballpark where the abnormality is, but the contrast recovery is pretty poor. And if we do an ablation test, we remove the autoencoder here and connect the UNet directly to the output of the fully connected layers. We get decent contrast recovery. However, you get a lot of false positive in off ground truth locations. So whereas if you put the three parts together as the FDUNet, you get accurate localization and also decent contrast recovery, which is comparable to the prior guided conventional method, even without, like ours is achieved without prior guidance. So we assume if we use the prior, we can get better results. So we're going to test it. The way we incorporate the structural prior is at here. After the autoencoder, we basically use a grayscale DBT image as an additional channel in the UNet. So multi-channel UNet is not something like we propose. It's not something new. It has been previously used by others to increase the resolution, like the image quality of low dose pad, using MR guidance. So ours is just borrowing the same concept using high resolution structural priors to increase the image quality of low contrast functional imaging images. So this is what we get with what we call FDMUNet. So even more accurate localization and increased contrast recovery. So if we focus on the smallest size group, the root mean square error with the prior guidance in the FDMUNet increased further by over 40% comparing to our existing FDUNet. And also there's further a moderate increase in the contrast recovery using prior guidance in this network structure. And not surprisingly, the localization is near ideal because the model knows where the lesion is. So that's not surprising. So in conclusion, the three-part network that enables the FDUNet to outperform the conventional finite element-based method and other deep learning models in terms of overall image quality and the inclusion recovery. And also by further leverage the structural image as an additional channel into the UNet, we can further enhance the small inclusion recovery. So I did the very subjective metric, which I call it success rate. So if we say a recovered inclusion is in 1 centimeter vicinity of the ground truth location, and the contrast of the secondary contrast is less than 50% of the primary, we say that's a successful case. Like this is basically thinking if we're doing a diagnosis, we see something and how close it is to the truth, and if there's any artifacts that confounding the diagnosis. So if we use this metric to define the success rate, the FDUNet actually achieve a much better success rate compared to all other metrics. And also notice that the minimum contrast needed for cases for 90% of the cases above this contrast to succeed is only 1.2. So that dramatically increase the sensitivity of the optical image technology. So obviously, like I mentioned before, so the downsample is pretty aggressive to a small lesion. So next time, currently we're working on use a less downsampled image domain to try to further improve the small inclusion recovery. And of course, these very simple geometry helps in terms of benchmark the performance and help us understand the network. But the real bus is way more complicated than this. So we're leveraging right now using publicly accessible data set, for example, the Duke DBT data set. And also we're retrospectively curate DBT image within our own institution and trying to train the model with realistic cases. So this, before I move to the next part, do you have any questions? Go ahead.
When you're adding the DBT as an extra channel to the reconstruction, does the DBT, is it marked where the lesion is, or is it just on the DBT?
Great question. Great question. So right now it's very simple geometry. When we deploy the model, the DBT image will be just by itself with no need to mark. So that saves a lot of time, right? You know, like when it's radiology marking and it's time consuming back and forth. And machine learning is good. The one of the most one of the first successes of machine learning model is for segmentation. So we figure the model can learn, like we can learn where the suspicious place is, and then the optical measurement help to offer information whether the suspicion is has elevated HBT or not to help with the diagnosis. So yeah, so this way we don't need the radiology input, so it's much efficient.
So your first attempt was using the fully connected layer to go to the image domain, right?
Yes.
Like at the beginning.
Yes.
At that point, were you labeling like what the image should look like at the first layer? Or did you just have a fully connected layer and then subsequent layers that were like doing analysis?
No, we don't have. So the fully connected layers, which we don't have explicit information for them, like where this optos is and where the corresponding image space is. It is the relative positioning or the spatial distribution is learned. We didn't give any instruction in that.
Yeah, so then the next approach was to have an input channel with the image directly.
You can do that. Yeah, you can do that. So
That's what the FDM.
Yeah.
So I did my PhD with Matt Rosen with
Mm.
AutoMap. So I would say perhaps like right after the fully connected layer, you have a deep supervised label that the fully connected layer learns the image rather than just trying to just have a fully connected layer without informing what that is supposed to learn. Perhaps that might help rather than just having the FDM put it.
Yeah. I feel like there's definitely room of improvement, and the labels can enter earlier, as you said. Yeah. So we're like when we incorporate the structural images, there are multiple ways, right? So we're trying to introduce that earlier in the network. So yeah, hopefully that will improve. Okay. No more questions. I'll keep moving on. And finally, as promised, brain imaging. So change gear quite a lot from optical imaging to machine learning to MRE. I'm very, I don't know how to say it. So some of you might have heard already. So over the last few years, I've translated MRE elastography to Bay 1 and Bay 4 at Martinos, and I just want to give you a brief review of what the setup is like and what it can do and how we use it for brain cancer imaging. So MRE is a MR technique that measures the stiffness of the brain, and it requires external stimuli. So it is some of the if you're familiar with liver MRE, they use the pneumatic shaker that send compressed air through a tube to underneath the head to shake the head. So in our setup, however, we use the eccentric mass. So basically, we have this black thing is a long axis. It's connected here, and it drive a pulley system to rotate this eccentric mass in a plastic casing that drives the vibration. And we use a stepper motor that's placed in the control room and connected to this long axis that goes through the waveguide to this patient bed to synchronize the vibration with the acquisition. And the MRE basically is a phase contrast MR pulse sequence that is time locked to vibration motion. And we use motion encoding gradient to measure the phase shift at several different points on the sinusoidal wave to help reconstruct the wavelength, the shear wavelengths, which is correlated with the stiffness of the brain. And the phase image, once propagation at different phase, looks like this. And from here, we can solve the Navier equation, and you can see here if there's a solid inclusion in the medium, the wavelengths increase, and from the shear wavelengths information, we can calculate the storage modulus, the complex shear modulus, and the first part is storage modulus, which is correlated with the stiffness of the brain. And some people has been using the second part, the loss modulus, to characterize the viscosity of the tissue as well. So yeah, so it's basically from this phase contrast images, you can resolve the shear wavelengths of the brain. And then like as you can see, once this overlap, it aligns with the structure of the brain pretty well. So I'm rushing through it because we have like not much time. I want to make sure I go through all the slides. So MRE has been used in in brain cancer imaging, mostly in qualitatively to evaluate the stiffness of the tumor before the surgery. So the surgeons can choose whether they can just use a suction tool to do a minimum invasive to suck the soft lesion out without a large invasive open skull surgery. And here we want to use it quantitatively to see whether MRE can be used to differentiate a very challenging clinical question, whether enhancement in the brain is a pseudo progression or true progression. So the disease in question is people with glioblastoma. So as you may know, glioblastoma is a WHO-defined high-grade IDH wild-type glioma. It's very aggressive and it always recurs, and you don't know when it recurs. And the patient who are diagnosed with glioblastoma has a very dismal prognosis with a mean survival of only 15 months. So it's a very fast progressing disease, and 5-year survival is only 5%. So current standard of care of glioblastoma is to do like take as much of the lesion as possible and safe to the patient, and then and after the surgery you get the concurrent radiation and chemotherapy. We get chemoradiation therapy, and after that you get 3 or 4 weeks break, and you get post radiation MR scan as the baseline. And then each month you get like a new dose of chemotherapy as the maintenance for disease to prevent the recurrence. And every 2 months also you get the surveillance clinical MRI just to track the progress of the lesion. And this is a typical example of a longitudinal clinical MR scan of a patient. And this is before the surgery and after surgery. And you can see there is increased contrast enhancement at the first and third post-radiation MR surveillance scans. And however, at the ninth cycle, it resolved by itself. So this is a typical case we call pseudo-progression. And about 36 patients who received the chemoradiation therapy developed this kind of situation. So basically, it shows contrast enhance, which is caused by temporary breakdown of the blood-brain barrier due to the radiation, and it doesn't need intervention. They can recover itself later. But there are patients, those are real progressions. For those patients, you can't wait. You have to act fast. And judging from they only have a 15 months like overall median survival, so that time lost in waiting and trying to decide whether it's true progression or pseudo progression is very costly. So can we use MRE to differentiate pseudo progression versus the true progression? So the pathology basis is there. So the active tumor is, as I mentioned earlier, has the signature of densely packed atypical cells, and also angiogenesis promote this macrovascular proliferation, and both of those can drive the local tissue stiffness to go up. However, as the tumor progresses and then it leaves behind, like invade into surrounding tissues, it leaves the center core, a necrosis core, which soften the tissue stiffness. So that creates a very heterogeneous distribution of the biomechanical environment of the tumor. And we know glioblastoma is very heterogeneous in terms of genetic markup and also other properties as well. However, treatment-related changes is different. It doesn't have those like densely packed cells, and it mostly reaction to the radiation is caused like cell death, necrosis, and which are very bland, uniform, and the inflammation can also cause edema, and that cause the tissue stiffness to go down. And actually, Sam and a collaborator, Dr. Schriegel, also did an animal model of glioblastoma several years back, and they find out a typical viable cells do have tend to have slightly higher stiffness in the tumor, and the area that has like necrosis left behind, DNA cells from split out from the nucleus left behind a very soft tumor core. And in areas where you see peripheral blood vessel increase, you also see an increase in tissue stiffness. So there might be something interesting for MRE to tell. So our goal is to use a high resolution MRE technique to map the spatial heterogeneity in tissue viscoelasticity of glioblastoma patients and see if it can be used to differentiate between pseudo progression and true progression. So I want to emphasize that the high resolution is very important here because we did several different spatial resolutions, and you can see at lower resolution you really can appreciate define this differentiate between a different part of brain, the wet matter tracts, and however, typically other groups has been using resolutions of 2 or even 3 for brain tumor imaging, which can be limited in this particular task. So we just started this project like last May. So we completed 3 patients and we're following 2. So, and nobody else has studied the MRE signatures of treatment-related changes. And so we don't know exactly what we're expecting. We have a sense, but we don't know. So I'm just going to show you some early images of 2 different patients. So this patient has a high-grade IDH wild-type astrocytoma. It was classified as glioblastoma before the change of the standard. So as you can see here, the MRE when seeing the red tumor marking pretty much stable and comparable to the surrounding tissue. And this patient, at least at that time period when we scanned him, has a quite stable disease. There's no functional or anything progression. And if you look at the next patient, I want to mention that they are actually, the MRE map is in the same color bar, so they're comparable in terms of absolute values. You can see the next case, there are a lot of unusually high stiffness, especially around the margin of the tumor. And there are some necrosis changes, like for example, here it turns into necrosis on these images. I think the feature that interests me the most is here. You can see this high stiffness line aligned almost perfectly to this the curvature just right outside the tumor. And we know as tumor progress, there can be accumulation of solid stress. So we're wondering whether this is the solid stress we're seeing. And actually, this part of the tumor did grow quite a bit from between the 2 time points. So we're still following the patient and want to do more patient and see whether we can draw any quantitative measures to differentiate the 2. But so far, it seems quite interesting, like just between the 2 cases, we see very distinct features. So just one quick slide. So MRE is also very sensitive to demyelination. So there are people who have been using MRE to, the brain stiffness is known to decrease with agent because naturally occurring demyelination associated with agent. And also the global brain stiffness also decrease when some neurodegenerative disease such as Alzheimer's and multiple sclerosis. So there can be other potential use of the MRE technique we have here. So in summary, we have developed high resolution MRE techniques that can quantify the heterogeneous distribution of the viscoelastic property non-invasively in vivo. And also the preliminary result shows that MRE did offer some independent information, some some information that's independent of the changes in other imaging modalities, which can be used to assist the clinical assessment of the treatment response. And we'd love to validate what we're seeing with pathology validation. So we're working with surgeons to get preoperative MRE, and we identify the regions that has interest contrast on MRE and ask the surgeon to sample, and so we can do tissue correlation. So that part of the project is ongoing. And we also want to develop a whole brain high-resolution MRE pulse sequence. So currently we can only cover 27 slices at 1.5 spatial resolution, that basically 40 millimeters block. So some lesions, I can see that last patient has a pretty massive lesion. So we are missing opportunities by not covering the whole brain. So we're working on Tuisha to try to use her EPTI readout to develop a high efficiency whole brain technique. And of course, we want to work with anyone's interested in using MRE to study other diseases such as neurodegenerative disease. Okay, with that, I want to thank all my collaborators within the Martinos and across the institutions, and also my funding sources. Thank you.